Ladies and gentlemen, how are we today? Can I get a bit more energy? I know it's been a long day. How are we today? Are we good? Excellent. Thank you. Thank you for making time and joining us today. My name is Alan Kasuja. I'll try to make this session as painless as possible. We'll have a very robust conversation about how to end TB in Africa in the shortest time possible. How many African countries are represented here? Let's first of all acknowledge the presence of Her Excellency, the First Lady of Malawi. She is very serious about fighting TB. And honestly, you don't get the level of commitment from someone as important as her across the continent. And she's an example and a trailblazer, and we honor you for that, madam. Thank you very much. I was told about her spending some time inviting TB survivors into the State House so that she could interact with them. Just imagine what that does for stigma. So it's really important that you're at the forefront of this fight, and hopefully when you get around with fellow First Ladies, you can encourage them to participate as well. We also have with us the Honorable Minister from Malawi as well. So Malawi is very heavily represented here. Mulibwanji. Zakomo, thank you very much for coming through. And it's good to see that level of commitment from Malawi, because they've seen TB as a problem that has to be sorted out. Which other countries? I sense a few Kenyans here. Kenya? Kenyans are usually quite loud, but today they're subdued. Probably as loud as Nigerians, I'm not sure. Any Nigerians here? They're on their way. Anybody else represented? Any African countries? Okay. I'm Ugandan. So yeah, Uganda is represented as well. But everybody, wherever you're from, thank you for coming here. Karibu sana, as we say in Kiswahili. Akwaba, as we say in West Africa. What does Akomo mean? Is it welcome or thank you? Zikomo. Thank you. There you are. Thank you. Thank you very much. It works for more than thank you. Zikomo. So if you want to pick up a Malawi word for your next party trick, it's Zikomo. Okay? It will take you anywhere. Thank you very much. I also just want to recognize some other TB champions that are part of this conversation later today. You'll be hearing as well from Dr. Atul Gawande. Let's give him a round of applause. USID is doing a lot for the fight against TB. You'll hear from him very shortly. He's the assistant administrator. And it's also great to have the executive director of the Global Fund, Peter Sands, here. And another very important person, someone who's coordinating all the work that's happening in Africa, someone I've had very robust conversations with, Chimwemwe, is from Nepal. Let's give her a round of applause as well. And she's from Malawi. So I won't be surprised if Malawi gets across the line before everybody else. Okay, right. To get us started, ladies and gentlemen, give a round of applause to Luchika. And by the way, Luchika and your team, what a setup. What a brilliant setting to have a conversation like this. Lee and everybody else that has worked very hard to put this together, thank you very much. This is a fantastic place to have an important conversation. Luchika, welcome for your opening remarks.
Thank you so much. Good evening, and I will be very brief because I know time is limited, and we have the First Lady and the entourage with us in time, so we need to keep in time because otherwise it's not polite. And I'm learning from Her Excellency, the Ambassador here, some diplomacy and some good tactics. But first of all, thank you all for being with us today. It's a great honor. Your Excellencies and Malawi team, I think this is the Malawi year, okay? And we should have Malawi shining, culminating with the Global Fund Board in November. I know Peter will say more. And we are very honored to have the entire team here as well. We know that few African countries' teams are on their way to arrive here, leaving a bit late from the Palais. As you know, there is still conversation, and TB topic is coming now. So I get messages saying, should I stay there? Should I come here? I say, stay and read. You anyway. The day will come. We in Stop TB decided to shift gears in African continent. As you all know, we did a lot of push in Asian countries, and I felt that I feel so much at home and so much warm towards Africa, but I don't think we really did as much as we could in the African continent. So that's why we decided to really, in partnership with obviously our board, the African Union Commissioner, and our champion here, the First Lady of Malawi, and the team from Malawi, the minister, to really raise not only the awareness, but also the attention, hopefully to have some robust conversation on financing, domestic, international for TB, and also reaching the targets for ending TB. The last thing, because I don't want to take the time of so many amazing speakers we have here lined up, African region has the potential to really end TB and to really show the world how it's done. In Africa, actually, for those of you not aware, during COVID, we didn't see the heavy impact on TB response as we saw in other parts of the world. And it was really very well done. And, you know, it was amazing to see, because we were predicting disaster, but actually in African countries was much less than, for example, in other parts, especially in Asia and Europe. So there is the potential there. I think there is the goodwill there. I think it's time to come together and putting and pushing forward a common agenda, not a separate TB agenda, because that, as I said, will not fly. But within the context of your health agenda, of your UHC agenda, people with TB, as we said, and as our friend Naomi here said, you know, are always forgotten. And they are very often the ones that are more difficult to be reached with services. If they are reached, we are close to UHC, because it's a very good metric of UHC reaching people with TB. So with this, we are very pleased to have you here. I know that we will have several other countries coming, but we need to start, so I'm giving back the floor to you, Alan. Thank you.
Let's give Luchika a round of applause. And right now, ladies and gentlemen, Her Excellency Monica Chakwera, who is the First Lady of Malawi, will come up and speak. Let's give her a round of applause, as she said.
It's a little bit, it's a hot seat here. I'll try to make it as cool as possible.
Your Excellency, before you start, please allow me to ask you one simple question. Why do you care so much about TB?
I think for me, my
Could you move the mic?
major concern was the stigma part of the whole thing. We have so many diseases in Africa, as you know, but in addition to the pain that you're feeling, add stigma, it makes it worse. So that's why I was like, maybe I need to do something to try to reduce that.
Thank you very much, Madam. Let's.
So can I start my prepared
Yes.
I'm pleased to bring you warm greetings from Malawi. Moni, that's our greeting, so it's not very difficult. Just M-O-N-I. You're there. Morning, yeah. So I come from Malawi that, like they have already said, we call it the warm heart of Africa. When you go to Malawi, you will see everybody smiling. Whether you have anything or you don't have anything, you are happy. That's the Malawi. That's why we call it the warm heart of Africa. And I am happy to bring warm greetings from that country. So in September 2023, I graciously accepted to be appointed champion for Stop TB. Of course, at that time, I didn't know what it meant really, and maybe I'm not there yet, but I have a little bit of what it takes. And like I said, I think the stigma part of it was the one that really touched me to say, I think we need to do something. It's true that we should do something. So like it has already been said, I'm not very good at health issues. I'm not a health person. So I had to learn a few things. So now, while the realities and priorities are distinct across our countries and regions, COVID-19 experiences, like they have already said, taught us some crucial lessons. Among them, that we living in a highly volatile and predictable times with shared risks across geopolitical frontiers, economies, creed, and health systems. Our collective health threats require our collective resolve and joint efforts to overcome them. No one is safe in one part of the world until everyone is safe in the rest of the world. It is this connection that I formally accept the challenge in the hope that we will walk every mile together and overcome TB globally together. Through various outreach platforms and means and across all regions, we must jointly amplify the voices of TB patients, health workers, and survivors until our governments and development partners stop promising without actions on commitments, but respond with real-time delivery of desperately needed solutions to address this global challenge, TB. In Malawi, we tell our people an adage that we usually say, nothing for us without us. So for everything is nothing for us without us. So even for solving these type of problems is nothing for us without us. So we have to be involved. Everyone has to be involved. We must work together to win this battle. I wish to extend my gratitude to the organizers of this event tonight for the honor to share with you a few reflections on behalf of the people of Malawi, and indeed on behalf of all TB patients, survivors, and caregivers, and not the least as champion for the Stop TB partnership, given that about 30% of people globally and in Malawi are unable to access TB diagnosis and treatment. What is Malawi already doing to make people more aware about TB? So like it was already talked about, on 30th April, I hosted a luncheon I had 120 TB survivors at the palace in Malawi in collaboration with Ministry of Health and Paradiso TB Patient Care. Paradiso TB Patient Care and the Ministry of Health, with support from Stop TB Partnership, are collaborating on support for LTB diagnosis, treatment, and rehabilitation. They also focus on advocacy to reduce stigma and discrimination. The luncheon was also attended by chairperson of the Parliamentary Committee on Health and chairperson for the Parliamentary Caucus on TB and experts from non-state actors, traditional leaders, media, and hospital personnel. The testimonies from our 4 TB survivors were most outstanding. What was most striking were the challenges like adhering to medication without adequate food at home, the out-of-pocket expenditures to afford nutritious diet and impact on household economy when the primary breadwinner is the patient. As you know, in Malawi, it's mainly rural and it's a poor country and people are poor. So when they say when they are on treatment, there isn't enough food, it's a fact. I could not resist the deep reflection on the faceted adverse impact of the experiences which subsequently would affect children's education, women's protection, households' livelihood, and the government workforce. For me, my passion is girls' education because we are lagging behind. These experiences are common among all TB patients in developing countries, particularly the sub-Saharan Africa. I assured the TB patients and survivors in Malawi that I would be with them all the way, be their voice everywhere I go, and ensure that their voices are heard and shape TB interventions and policies in Malawi and the SADC region. As you know, when somebody knows or has been diagnosed with TB, sometimes it's like it's a death sentence. But we are working, I think the minister here can agree with me, to help them, at least in their mind, psychologically, take it. They can get help. So that's the main thing. And then when somebody says, I had it, I'm now okay, that gives them hope to work even better. So we are sort of like trying to work in that direction that by 2030 we are there. We want to eliminate it. But while we are on our way there, we have to encourage everyone, even those that are at risk or something that, you know, it's a curable disease. It can be cured. My presence today underscores our highest commitment to taking decisive action to end TB globally by 2030. TB is the second deadliest infectious disease globally, trailing only COVID and surpassing HIV/AIDS in mortality rates. I am sure you already know all these things. You are more experts at this than me. So I think you already know the statistics. I'm not going to read them out here of where we are on TB. So the statistics in Africa and particularly the SADC region are equally alarming, like the world statistics. And in Malawi, 26,000 TB cases were reported in 2021, resulting in 3,000 deaths. Additionally, 45% of TB cases went undetected. That's, I think, the area that we need to work hard on, because when it's not detected, it can spread. So this indicates that a significant number of people suspected of TB who were undiagnosed to receive appropriate care is still alarming. We still need to work on it so that we don't have that. Despite the low detection rate, Malawi has made remarkable progress. The incidences of TB have declined from 338 per 100,000 people in 2010 to 125 per 100,000 people in 2022, which is a 61% reduction over the 11 years period. In the past 6 years, TB treatment success rate has also increased from 82 in 2015, 82% in 2015 to 90% in 2022. I think we are heading to zero in 2030. So maintaining this trajectory could help us achieve the end of TB by 2030. The proportion of TB patients co-infected with HIV has decreased from 77% in 2003 to 47% in 2023. Additionally, the treatment success rate for drug-resistant TB has improved from 55% in 2018 to 78% in 2020. So I think we're heading the right direction, and we will make sure we do that so that by 2030 we can come back here and report to you that we are there. I'm hoping. Social determinants such as geographical location, poverty, poor nutrition, low education levels, and HIV/AIDS co-infection heavily influence the development, transmission, and detection of TB everywhere. We recognize that TB's economic impact strains the labor force, exhausts government health budgets, and depresses household economies through out-of-pocket expenditures. In Malawi, a survey in 2020 showed that about 23% of Malawians incurred catastrophic costs defined as more than 20% of annual household income while seeking TB care. The poorest in our communities often feel this burden most acutely, and they survive on less than $2 per day. Often these are the people facing intertwined social determinants: low education, lack of information for diagnosis, treatment, and rehabilitation, and the inadequate nutrition. To address TB effectively and end it by 2030, our clinical interventions must not be a one-size-fits-all, but must integrate intervention to address these social determinants at the community level, bringing TB services closer to the people and considering regional differences between countries. In Malawi, our success stems from several integrated medical and social interventions. So allow me to share just a few of these. So one is scaling up of house-to-house TB screening, TB contact tracing, and mobile diagnostic units. So mobile vans have TB services to the communities. Like I said, Malawi is a rural country. So transportation, whatever is very difficult. So you can't expect those people to go. So for screening, at least diagnosis and knowing that we have a TB situation, in this case, these vans go out to the communities to screen. So that has proved to be very, very helpful. But of course, we don't have enough vans. If there was any help, I think we would have. We have 28 districts, and we have 7 vans. So at the moment, we need more, because that's easier to detect and therefore eliminate, I think. So there we are seeking more resources to expand such intervention nationwide, including mobile technologies for self-screening. These ones are very, very helpful nowadays. With new technology, I think we are getting there. 2030, we will be clean. In July 2024, we plan to conduct patient visits in TB management hospitals and post-lung diseases rehabilitation centers. This initiative supports patients, normalizes seeking medical care for TB management, and reduces stigma and discrimination. Why my number one aim is to reduce stigma? Because the stigma will make people hide what they have and what they are feeling. And if they know that it's okay, then they will come out for help, and then that will help us reduce the infection to other people that don't have the disease. So in August 2024, we will conduct TB awareness campaigns at national level. We intend to host a high-level TB awareness forum, engaging community leaders, partners, and media as key channels for information dissemination at community level. If chiefs and leaders in the communities are involved, that makes life even simpler to the ordinary village person. In September 2024, we would like to ensure that we bring a representation of TB survivors at the United Nations high-level meeting, if possible. If funds are available, we need help. Somebody can, I'm a church person, So we call it a testimony. If you say a testimony of what happened to you and how you were rescued or helped, it goes a long way in somebody's mind to say, if that one did that and was there, I think I can also. So these type of things go a long way in helping out other people that would have felt stigmatized. They can reach out and get help. As government, we have also engaged the media to publicize TB awareness through media platforms, influential community leaders, and community meeting forums. We have integrated digital health solutions, streamlined recording and reported processes for TB diagnosis. We have improved our infrastructure and equipment, including modern diagnostic machines like GeneXpert, I hope I'm pronouncing it right, and X-ray machines to enhance TB detection. We also have ongoing capacity building for healthcare workers, and an interrupted supply of anti-TB medicines have been very crucial. We have started providing food packages to our TB patients every quarter, including cooking oil, sugar, soya milk, and beans. For all this to be achieved, there is need for significant investment in the Stop TB campaign. The government of Malawi prioritizes resource allocations and utilization in the health sector, demonstrating solid political will. So I'm standing here, we're demonstrating solid political will. I think by 2030 it's a goal that we can say, and my Minister of Health is right here. I think we will achieve it. I hope we can come here 2031 and report that, oh, we are free. However, the need is huge. Many study countries and beyond face resources constraints, leaving vulnerable patients at risk of poor treatment outcomes and drug-resistant TB. And you know, we are neighbors, so we may end by 2030, but we want our neighbors also to end so that we can stay free. We need integrated TB interventions at the community level. I call upon regional commitments of governments and more partners to join hands in driving the Stop TB campaign with a deliberate focus on an integrated approach that provides TB services closer to the people and with social interventions that addresses the social determinants. This World Health Assembly acts as a platform for advocating for more commitment, actions, and funding towards NTB by 2030 in our countries. Distinguished ladies and gentlemen, in a special way, let me thank the following institutions for the great job that they are doing in our country in Malawi. The Paradiso TB Patients Trust, Stop TB Initiative, Minister of Health, National TB and Leprosy Elimination Program, National Organization of Nurses and Midwives, and all civil society organizations who are working tirelessly with volunteers in the 21 districts of the 28 districts we have in Malawi. Many other countries in the SADC region and sub-Saharan Africa share our challenges and struggle to improve TB services with an integrated approach that addresses the social determinants of health. In conclusion, as the First Lady of the Republic of Malawi and the TB champion, I urge all of us to commit to financing Stop TB initiatives, addressing the social determinants of health, and encouraging one another. Together we can end TB by 2030. Let us make TB history. Yes, we can end TB.
Excellent. Let's give another round of applause. She truly deserves one. Just remember, she needs money for more vans and a little bit of cash to help testimonials travel That would be really nice. So if you have some money on the side, I know Chimwemwe has some money somewhere. Okay. And then we also, at this moment, before she settles down, Madam, you've decided to bring something from Malawi for Luchika. And Luchika, there is a gift for you from the First Lady of Malawi. Let's give a round of applause. Geraldine is going to take a picture of this very important moment. I don't think Luchika gets as many flowers as she deserves. So this is a really big moment. Let's give her a round of applause. She fights TB, no holds barred, all guns blazing. So by all means, she must be recognized for the important work she's doing. Now, next we're going to hear from Dr. Atul Gawande. Now, Dr. Atul Gawande is the USAID Assistant Administrator for Global Health. And let's pause for a second and recognize that USAID is at the forefront of funding efforts to fight tuberculosis across the world. And everybody that you hear about, the TB Partnership, Global Health, all get their money from the US government through USAID. So it's really good to have you here, sir, and welcome.
Thank you. Thank you. And thank you for those wonderful words, First Lady. I'm going to try in 5 minutes to give you hope. That's my target. It is hard to have hope in TB. In 2018, when we had our high-level meeting, we had missed our targets then. And now in 2023, when we had the UN General Assembly high-level meeting, we had not only missed our targets for lowering TB, but TB deaths had gotten 7% worse. Funding has been pretty flat in this line of work. The challenges are huge. This is a disease that has killed more than 1 billion human beings, the worst infectious disease in history. This is a disease that's hard to treat because you all remember asymptomatic COVID. Well, TB is asymptomatic for months after you've been exposed, and it sits there in your body and then blossoms and infects more people, not only yourself. So where is there hope? Number one, since 2000, your work, the people in this room and well beyond, have reduced the rates of TB cases and deaths by 2/3 over time. Now, it's been a struggle under COVID, but already we have signs that the lost ground is being made up by the return of TB capacity, TB expertise, to focusing on TB again rather than on COVID like we've had to focus on. The second area I really want to focus on is how innovation is changing the game. And I can't go through all of the examples that I really would love to give. I have 5 pages that I could. But I want to highlight a few. USAID has really shifted. If you're a flat funding world, we know we can't hit the targets with the tools that we have. But the tools are changing, and we need to accelerate that. And USAID has played a role in financing more than 40% of the research and innovation in this space, and we intend to keep on doing that. As an example, the introduction of AI-based chest X-ray technology, so digital X-rays you can carry in a backpack at a primary healthcare level that can be used, and a software on a laptop can diagnose what's seen on the chest X-ray. We're deploying that in 6 African countries, including DRC, Kenya, Nigeria, Tanzania, Uganda, and Zimbabwe so far, and more to come. And in Nigeria, that introduction, coupled with access to molecular TB diagnostics that give you a same-day result, enabled case notifications to increase by 1/3 over the course of a year. So you could find 1/3 more cases and get people on treatment. Second, in Malawi, by the way, introduction of digital chest X-ray tools we haven't got the AI-based system coming yet, but that can come, has already reduced, as the First Lady said, reduced incidence by 37% by capturing TB cases and enabling people to get on treatment. Now, the second thing I want to say is that we know the strategy that works for eliminating TB, and it is not enough to be able to screen and diagnose and then get people you find with TB on treatment. The further part is to do contact tracing and get people on preventive treatment, often children or other family members or people living in crowded environments. This is a disease of the downtrodden, of the poor, of the vulnerable, of the forgotten. And they do not, prisoners, refugees, people on drugs, these are not the people that, I call it the stress test of the soul of a country's health system, whether you're taking care of people with TB. And so you need to be able to have the community health workers venturing to those homes, contact tracing, and then identifying those people to get on preventive treatment. Preventive treatment has been expensive. So another source of hope is that not only with Global Fund and other partners have we lowered the cost of diagnosing TB by 20%, but now we've joined together and negotiated with Stop TB and others here, a 30% reduction in the costs of preventive treatment, the critical part to shutting off the tap that's fueling the cases. And to go a couple steps further, number one, to diagnose more effectively, USAID has been working with a variety of settings, but including in Nigeria and in Zambia, introducing and testing stool-based testing. It's difficult to get children to cough and produce a specimen to confirm they have TB. But with stool-based testing in Nigeria, it is being found that it can be easily implemented. Out of 50,000 children tested, 2,400 were found to have TB and were begun on treatment, children who never would have had that treatment begun. Then with preventive treatment, not only have we lowered the costs, but we have worked with engineers to find ways to lower the cost of the manufacturing processes too. And then with the rights to those approaches, we have done a technology transfer to an African manufacturer in South Africa, CPT, a company there that is the first one to be able to produce now rifapentine, this key medication.
The three that we were making least progress on. That has changed. And remarkably, although COVID hit progress on TB harder than the other diseases, the bounce back has been even more remarkable. And that, I think, is testimony to the ambition, the determination, the energy of so many people across the TB community, whether it's in national TB programs, ministries of health, whether it's in Stop TB, whether it's in communities and civil society groups fighting TB on the ground. It's been a remarkable story. And it's all the more important that we sustain that story. So I was just going to offer a few quick observations on ways I think we can make that happen. First, use TB to turbocharge progress towards UHC. The things you have to do to make TB work are ultimately a big part of what you have to do to make UHC happen. Not least the fact that you have to reach out to, as Atul put it, the most downtrodden, the most marginalized, those, as Your Excellency said, who are stigmatized. And don't think that I've just dreamt this up. Japan. Post-Second World War, biggest killer in Japan was TB. 1951, they launched a national TB program covering the whole country, really ambitious program. 1961, they essentially turned that TB program into what they called UHC, and Japan came up with the term UHC. And so this is not a sort of theoretical construct. This is a tactic that has been used and used very successfully. Okay, second point, building on that, is use the fight against TB to build pandemic preparedness. Because once again, a lot of the things that you need to do to fight TB, whether it's in diagnostics, infection prevention and control, broader public health measures, care pathways, the whole array of things you need to do for TB, and a lot of the scanning and use of AI and all that kind of stuff, massively helpful when you're thinking about the threat of new pathogens. Again, not my bright idea. I go again to Japan. Which of the G7 countries outperformed all the others in terms of the response to COVID-19? Japan. How did Japan do it? It did it using a lot of new technologies, obviously, but also the basic kind of infrastructure that it had put in place to fight TB. And places like Korea did a lot of the same things. So fighting TB is both a really powerful thing to do in its own right. It saves a lot of lives, but it's also a fantastic way of accelerating progress towards UHC and reinforcing pandemic preparedness. Third thing, spend more money on it. In most parts of the world, most of the money being spent on TB is actually from domestic resources. Of the amount that comes from external funding, 3/4 of it comes from the Global Fund, most of the rest comes from USAID. But the money that comes from USAID and the Global Fund will not be enough to beat TB. And the reality is the proportions of external funding to domestic funding in Africa are not the same as they are elsewhere. To put it bluntly, not enough domestic resources in Africa are being spent on TB. So we do need to convince finance ministers to up that bit of the budget line. And this is me talking as a banker or an economist. That actually shouldn't be that difficult, because the return on investment in fighting TB is incredibly high. Anglo-American, the big mining company, has significant operations across Africa. It has about 50,000 employees. It wasn't long ago, and they have joined the, what's it called, Luchika, the TB in the Workplace initiative. Right, and they joined the TB in the Workplace initiative. When they started, their annual number of TB cases that needed treatment was about 800. Now, when you think about it, 800, that's 800 people who, for the most part, are out of work for the best part of a year, right? So that's 800 full-time employees. You work out their average employment costs, you can work out the cost to the business. 4 years later, that number was 8. That was and that business case is a really, really powerful business case. Now, I don't think Anglo-American are unique. I think every single business in Africa that is employing significant numbers of people will be bearing a cost of employees who fall sick and therefore cannot be productive. We need to find ways of engaging them, but we also need to make finance ministries understand that the national productivity is being impacted and that actually you can fix this relatively quickly. Next point, take advantage of all the innovations and cost reductions that Atul was talking about. We actually have, in the last year, seen the most dramatic change in the price of TB inputs that we've had for a very long time. A 20% reduction in gene expert cartridges, a 55% reduction in the cost of bedaquiline, a 30% reduction in the cost of the preventative medicine. We need to take full advantages of those, and we need to take advantages of all the other tools that Atul was referencing. And as he said, there are a lot more of those sorts of innovations. And then finally, and this, I'm so glad that you started, Your Excellency, with this, is we have to tackle the stigma. The big challenge in fighting TB is finding the people who are affected by the disease. And finding people who don't want to be found because they've been made to be ashamed is a really difficult problem. And it's not a medical problem. It's a social, policy, political, societal problem. And in a sense, we will have to spend collectively a lot more money if the people we're looking for are hiding. If we make it easier for them to recognize that they are sick and that they need help and that they need treatment and that they can be cured, then the whole thing becomes so much easier. So I actually think we're in a really kind of exciting moment. We have momentum in fighting TB. We have tools and innovations. We have price reductions that make the economics better. So it's kind of in our hands to make it happen. And I think we can make it happen, and we can end TB. Thank you.
Thank you.
Wow.
Thank you.
As you sit down, and please feel free to remain seated, Mr. Sanders, I'm really curious about the involvement of the private sector, because you make that point of the reduction that happened in Africa. The government will argue that its resources are exhausted. Private sector clearly has a role to play, does it not?
Absolutely, the private sector has a role to play. And actually, the TB in the Workplace initiative has attracted a lot of companies, but more in Asia, I think, than in Africa so far. So I think we should think about how we energize more African companies to engage with national TB programs around case identification. It's interesting. Japan, at the height of its national program, because I was really interested to understand what happened to Japan. So I went to the center where all their program had been driven from the 1950s. One of the things they did is they made employers responsible for ensuring that all their employees were tested for TB. Now, just imagine how powerful that would be if you could get that happening. Now, I appreciate that some of the populations most at risk from TB aren't in formal employment, so you're not picking up the whole. So there are things that governments and civil society will also have to do to reach out to the most marginalized. But you can also leverage the power of the private sector in this.
Thank you very much. And Your Excellency, the First Lady, I think Dr. Lazarus Chakwera can, if you talk to him, we can see Malawi do something about the private sector's involvement, and we could learn a few lessons from that. And in a few moments, you'll be hearing from Naomi. If you haven't heard her story, who has heard her story yet? She'll tell you about stigma, probably more than anybody else. She talks about it very powerfully, how the stigma started with her, stigmatizing herself, and the problems that resulted from that. So I look forward to hearing more from Naomi. Let's give everybody a round of applause. I think... And before we go, I'd like just take this moment. Can I ask Atul and Peter, please, to join Her Excellency, the First Lady, for a photograph before we continue our conversation? Don't worry, this is what happens in places like this. People take pictures. These are important photos, so bear with me. Bear with me. These are important pictures, you know. Meanwhile, Dr. Matendechere from Kenya, Director General of Health, has also just walked in. Thank you very much for joining us. Kenyans, let's give them a round of applause. That's a beautiful picture. Thank you very much to the four of you. Thank you very much. Thank you. Thank you. I promise you the food we'll eat at the end of this will be worth waiting for. So stay with us as long as you can for it. In the meantime, the next stage of this conversation is going to have two very fascinating people. One of them is someone who's been on my podcast, which is called Africa Daily. We had a really robust conversation, and she knows what she's talking about. She heads a very important effort. She'll tell you more about it in a moment. Her name is Chimwemwe Chamdimba. Let's give her a round of applause as she goes up. Chimwemwe Chamdimba will be telling you about AUDA and NEPAD, and she'll be joined up there by Shawa Musonda. Shawa Musonda is from the African Union. Let's give her a round of applause. She's a technical advisor. And the reason why you have NEPAD and African Union up there is because we are talking about a regional effort. You know, it's really important that African governments are not working in silos, and that this effort, which has cross-border implications, geopolitical implications, is, what do you call it? A collaboration, right? Do they have microphones? Could we have pass the microphones, please? And just by way of introduction, Chimwemwe, just tell me a little bit about what you do, who you are, what your organization does as well.
Okay, no, thank you very much. I remember the podcast that you were talking about.
Yeah, why I
And,
asked you why governments are not signing up.
You grilled me about why governments are not signing up to the African Medicines Agency. I recall very well. But I think you can see the commitment of the governments now that we are moving with the African Medicines Agency.
Are you saying there's more commitment now?
There's more commitment. We will talk about it.
Okay, the
Thank
numbers
you.
are better.
Exactly.
Excellent.
So no, thank you very much. And it was really fascinating to hear the First Lady of Malawi, HE, Monica Chakwera, who is also my First Lady. I think you were talking about the Malawi Mafia when you came up. I'm also from Malawi. My name is Chimwemwe Chamdimba. But as he said, I work for the African Union Development Agency, AUD and NEPAD. I lead the work on the African Medicines Regulatory Harmonization, which is the pathfinder for the African Medicines Agency. And I think I was really glad
And I'm really glad you do. You know, the regulatory issue is a really big issue.
Exactly.
You know, a lot of people have good interventions, but they just can't get it to where it needs to go because regulators are a problem.
Actually, the representative of USAID talked about it all. He talked about the examples of innovations that are in the pipeline. He talked about innovations that are undergoing clinical trials. But I think the question is, are we going to be able to take them to the people that need them? Are we going to take them to the last mile? What does it take as a continent to take these innovations to the last mile?
Okay, so if I understand you right,
Yes.
you're the person who will be able to, if you say yes, everybody says yes. Is that it?
We are the African Union.
Yeah.
And my colleague will also talk about it.
Yeah, but I mean in terms
Yes,
of regulatory issues.
On regulatory issues,
Yes.
so what we do as the African Union Development Agency with our African Medicines Regulatory Harmonization Initiative is that we support governments to strengthen their regulatory capacity and harmonize their regulatory systems so that they're able to work together to approve these products and get them to the people that need them. So the efforts that are being taken of the African Medicines Agency will really help us to take the products to the last mile. Because you see, there are certain countries that do not have the capacities. I mean, you're talking about these innovations that are coming up. Do we have capacities in our countries to be able to approve them and get them to the people that need them? I think the regulatory bit becomes quite critical, and the work that we are doing at the African Union Development Agency really is supporting those efforts.
Okay, Dr. Msonda, what work are you doing? You're the technical advisor. You're the one who comes up with the... Yeah, just tell us what is happening at the moment in as far as harmonization of the regulations is concerned.
Okay, yes. Good evening, everyone. So we deal with policy. So at the African Union, we develop the policy. We don't develop it on our own. We develop it in consultation with member states. So we sit back there and then we come up with ideas of how we think we should address the problem of TB in countries. And with the consultations of member states, we have recommendations. So we have very good policies in place. For example, I think we're working with Stop TB, WHO, we are implementing the NTB strategies. We have a scorecard that shows how the country is performing in terms of addressing a number of needs and challenges in TB.
And this is an updated scorecard.
Updated every year.
So what is it looking like at the moment? Which countries are doing well and which ones are struggling?
So I think I'll talk about one indicator, and I'll talk about it because when we go to meetings, that's the only thing, it's a major thing that comes up. You know, we are told we need political commitment, but we have our ministers here, we have our first lady here. This shows that the political commitment is there. And it has been there from 2001 through the Abuja Declaration. You know, we have, our leaders have told us they want us to end TB, they want us to end all these other diseases by 2030. I think the challenge that comes in is implementation and alignment. But in terms
What does
of
that mean? What does that mean?
So
I like simple language, sorry. But when you say alignment and implementation, what do you mean?
all right. So when I talk about implementation, so at a policy level, we agree that we need to end TB. And one of the ways that we need to end TB is through prevention, because we know that it's a cost-effective measure. And so what prevention looks like is that we're going to put in measures in place that will stop people, will either educate people, we're going to improve our infrastructure, we're going to improve, behaviors in our communities so that people don't get TB. So we have that on paper. But actually going on the ground and doing the actual work of, for example, doing health promotion, for improving diagnosis, buying, I think we heard from USID and from Global Fund of the new technologies, buying those technologies and utilizing them at country level. To get to that point is where the challenge is.
What is the problem, do you think?
So I think the problem, I think there are a lot of factors. So I would classify that as a complex problem, because it's not because of one person not doing the job, but it's because of several layers. You know, so when the heads of state take the decision and they give us the mandate to work, it has to go to our government officials. The government officials have to cascade that down to the communities. So that whole process, and you know, when you're dealing with people, it becomes a challenge. So in terms of political commitment, I think we're there.
Okay, political commitment. We have a minister here from Malawi. Madam, I just address that issue for me a little bit. We have a problem, the cascading happens. The President Chakwera goes out and says, this is the position, signs this document thing, policies exist, implementation is a problem. Well, what are you facing in Malawi? How are we addressing this issue here? We have to finish it here and today.
Thank you so much. She's being very polite, diplomatically correct. We have our first lady here, but in a layman's language, it's the bureaucratic processes in governments which
Okay.
delay things. As simple
Give
as
me an
that.
example of what you mean by that.
No, like she said, for something to move, a decision made at the African Union, which has to be passed on two governments, different governments, it lands on the office of the president, then it has to cascade to the line ministry, and then it has to go through the line ministry. It's all these things. There are so many red tapes in government. Those who are civil servants here, they would agree with me. And this is one of the challenges which we have been talking about. We cannot get things done. Simple things, which everybody else, they know what they're supposed to do. But it doesn't happen like that. So this is one of the challenges. It's a disease in itself.
Another disease on top of TB, you mean?
Exactly. It is a disease because it delays procurements, it delays projects. So many things are affected. But at the end of the day, we have to keep in mind is the one who's the most affected is the poor woman or the child in the village who need help, and they need it quickly.
Okay, I just want to. So that's the political angle. We have a technical person here, Dr. Sultani Matendechero. He's a Deputy Director General, State Department of Public Health and Professional Standards in Kenya. Please, if you may, please. Thank you very much, madam. And I just wonder, you technocrats, why are you the problem? Why? What needs to be done by the technocrats? The political will exists. The politicians have made a decision. The policies exist, but technocrats are a problem, clearly. What do you think? What has been your experience? And when you talk to colleagues across the continent, what are you hearing as the problems with the implementation?
Yeah, so I think we are very deliberate in our objective of being able to now end TB. And our objective is to do this by 2030. We believe that it is something that is achievable. I know that we have really been focusing on waiting, a passive approach, so that we wait for the cases to come to us so that we can treat. But now we are a bit more aggressive. We are going out to find the cases. We have adopted strategies which are aligned to the WHO NTB strategy, which actually now have bolstered our efforts to go out and do active case finding. You will realize that in Kenya, we have actually moved towards a community approach, which promotes a preventive strategy, where we get out to the community through our community health promoters, and they talk to the community members and encourage them to adopt practices that enable them to prevent infection, and also, to promote health instead of waiting for treatment. So it is something that we are addressing, and it can be shown, it can be seen in what we've achieved. We have actually surpassed the targets that have been set. When it comes to prevalence, we were able to reduce the prevalence of TB by, by about 35% against a target of 20% by 2020.
Okay.
And the mortality, we were able to reduce it by 42% against a target of 35%.
Very interesting, and Kenya deserves a round of applause for that. I'm just wondering, how can politicians and technocrats better collaborate to achieve the results you're talking about?
So this is something that you mentioned as I was just coming in about political goodwill. It is something that we really have to achieve through more strategic and effective advocacy. I think as the technocrats, we really have to bring it to the attention of the political leadership, because we understand that there are a lot of competing priorities. But then it is our job to try and make sure that we put in strong justification to the political leadership, and to make them understand that this is indeed a priority. Now, for example, in Kenya, over the last 2 years, we have been able to achieve phenomenal progress in terms of our legal framework, where we were able to enact 4 laws that will enable us to carry out, or maybe to actualize, our universal health coverage program. And this was because of the political goodwill that we have been able to establish in our new government. So it is just about being able to step up our advocacy strategies so that the political leadership can buy into our priorities.
Thank you very much, Asante Sana. Let's give him a round of applause. And Chimwemwe, yeah, please. Yeah, sorry. Chimwemwe, just tell me a little bit more about what your experience has been working with different African governments. I know I don't mention names because your position is quite sensitive and you need them all on your side. But just tell me a little bit about how some governments respond, how quickly it takes, and what the effective response actually looks like to an initiative like yours.
Thank you very much. I'm going to move away a bit from the medicines, my comfort zone. And I want to give an example of the work that we have done in the tuberculosis space, and where governments at the regional level have been able to translate political commitment into actual tangible, implementable programs. I'm going to focus on 2 programs that we have implemented at the African Union level. I think they were referred to in a way by the speakers that spoke before me, because I think there was an example of Anglo-American that was talked about when it comes to private sector engagement in TB. In the SADC region, when they were trying to cascade policies at the cascading that Sheila talked about, at the continental level, we have adopted the catalytic framework to end AIDS, TB, and malaria by 2030. And regional economic communities have tried to translate that into their own regional policies. And in the SADC region, they also adopted their own policy and their own strategy on addressing TB in a population that is at risk in the region, the mining sector. This is where they adopted the TB in the mining sector. Now, we as AUD and EPAD, in collaboration with partners, and we are glad that Global Fund was here, there was World Bank, WHO, we have worked with the African Union Commission and East and Central Africa Health Community to translate that policy into programs that have worked in the region. And they have enabled countries in the region to implement a number of interventions that are multisectorial in nature and regional in nature. A number of tools have been developed at the regional level. The cross-border referral system, for example, in the Southern Africa region, to enable movement of patients across the borders and getting treatment across the borders. The challenge.
Tell me what that looks like. What does that look like?
So I'm looking at in the South African situation, for instance, where I live, and there's a lot of mining, and Anglo-American gold that was talked about here is in South Africa. And you realize that in the mines in South Africa, it's not only South Africa that work in the South African mines. You will find Basotho in the South African mines. You will find Malawians, Mozambicans, Zimbabweans, and everybody from across the region, the SADC region and beyond, working in the South African mines. However, when these people, you realize that they are mobile populations. They don't move with their families. Their families remain at home. And they frequently move across the borders to the other side to visit their families and come back. And with the prevalence of TB in the mining sector, these are some of the populations that move TB from one point to the other. And I liked what the First Lady talked about earlier, that we can do whatever we can in Malawi, and by 2031, come back and say, we are clean, we are done, we are done with this. But however, if the others around the region where our populations go to have not dealt with it, we have not dealt with it. You are only as safe as your neighbor, because the neighbor will always come back with whatever you're trying to afford. So with this, the cross-border referral system had to have a lot of political commitment. I'm looking at my minister from Malawi. One of the countries that have implemented this are Malawi. They needed to be willing and ready to share information, to share data for their patients to be able to move across the region. So this has been done effectively.
So do you envisage a situation where a patient in Malawi can get treatment in Zambia if they need it, or in South Africa?
Course,
Is it something that's happening at the moment or not?
This is not seamlessly happening, but it is happening.
It is.
It is happening in the region. And with the work that we have done under the CBRAs, you see that the referral has started happening across the borders. Another important thing that has also translated into action is that we cannot, the issues that we talked about, TB, the socioeconomic issues, they are not just health issues. We cannot tackle TB only through the ministries of health. It's not just a health sector issue. We need, if we're talking about TB in the mining sector, we need to talk about occupational health. Occupational health and safety is not handled in the TB. I mean, in the health sector, it has to be the ministries of labor. The ministries of mines have to come on board to be able to also apply these laws that are being adopted through the ministries of labor. So you will see that a lot has happened. Recently, Lesotho actually, to end this, Lesotho actually was sending us a message that with the work that we have done, they've been able to pass a law, their occupational safety and health law, which they were reviewing through the efforts that were initiated at the SADC region. And with the learning across the region, they've been able to do something. So the hope is there, and
Right.
there's light at the end of the channel.
And Sheila, pick up on what she's just saying about the regional efforts that are happening and how much that would help. Because countries can no longer afford to work in silos, can they?
Yes, countries can't afford to work in silos. And I think I wanted to add from what she said about what Chimwemwe talked about when you talk about the, can a patient in Malawi get treatment maybe in Mozambique or Zambia? So we are going through the digital health agenda right now, where we want to digitalize everything in terms of health. And this has come about because, it's not only people who in migration, it's not only people who are migrating to work, but we have issues with refugees. We have issues in conflict settings. And you find that, for example, what is happening right now is that all the people in Sudan are actually either in Ethiopia or they are in Egypt, they're in different places. Now, remember that amongst those people, there are people with TB, there are people on ART, and they'll need to continue that treatment. And so one of the things that we're trying to work with is to ensure that regardless of where you are, if you have your records, you can access treatment. We're talking about free movement. We're talking about
And
migration.
this is a reality? This is actually happening?
It is happening. It is happening. So it means, for example, for those in refugee camps, until maybe we have mobile clinics, they will not be able to access the treatment. It means that they will not adhere to the treatment. It means they are at a risk of MDR-TB. So we have to find a way to make sure that it doesn't matter where you are, you should be able to access the treatment. So I wanted to add to that. But also, I think when I talked about the political will, I want to also address our partners. So I think another challenge that we do see when we're implementing policy is that you're talking about financing, isn't it? We know our governments have a lot of demands. And when you look at the AU policies, each policy would demand 0.2%, 10%, 15%, 1%. And so when, we had ministers who came and said, look, if we bring together what you're telling us to do in climate change, education, agriculture, peace and security, it's actually more than 100% of our budget. So the governments themselves are not able to do all this alone because of limited resources. And so this calls for the need for alignment with our partners. And we know that donors have their own, they have their objectives which they want to follow. And sometimes when they go to the country, it's because they have a set agenda of what they want to do. But the country might have a different priority. So one of the things that we also are trying to promote and advocate for is alignment. So when we are supporting our countries, we are helping them in their initiative. I think it's best to ask what the country needs and not what we feel the country should do. So that is very critical, because if we work with a country, so if the country says, I want to focus on prevention, I think there should be flexibility to allow them to work on prevention. But what is happening now is that the country wants to focus on prevention, but the aid is focused on treatment. And so even if the country tries to justify, to say we want to focus on prevention, it will not happen because there's no funding for prevention.
Maybe I'm just simple, but it sounds so complicated when the country now has its priorities. You're trying to make sure that everybody's on the same page. You're trying to create a regional approach. This all seems to add layers to the complexity, does it not? And then you also have regulatory issues to deal with because Chimwemwe is battling all these forces across the continent to make sure that the regulation is achieved. Isn't it that complex, or am I?
No, it is not complex. It becomes complex if we don't want to compromise. But if we are ready to listen to each other and compromise, it's not complex.
So who needs to listen to who? Is it the politicians or is it the technocrats across the borders? Who needs to listen? Who needs to go to dinner, have a cup of tea, have a drink, and have a conversation?
I think everybody. So the politicians and the partners need to listen to each other, compromise. The Ministry of Finance and the Ministry of Health need to listen to each other, because, the Ministry of Finance is the one that releases the money. And when we have conversations with them, what they usually tell us is that, you are not explaining it to us so well. If you had told us how important it is, we're going to give you the money, but maybe they were just not listening. So they need to listen. And then, everybody should try and listen and compromise and find a common ground. We should be ready to, lay down a bit what we want and then just see how we can work together. So I think compromise would make it easy.
Ladies and gentlemen, let's give them a round of applause. Please stay, remain seated. I'm not done with you yet. No, please. We are not done. This conversation is, I'm just checking things up because I redeem some time and want to make sure that you're fed. I just want to introduce you to one of my favorite people today. Please welcome Naomi. Naomi Wanjiru. Naomi Wanjiru is joining the two ladies. This is an evening where ladies are leading the fight against tuberculosis. Let's give her a round of applause. Very few people have helped me understand tuberculosis like Naomi has, because hers is a compelling story. When were you? Tell me a little bit, and please bear with me. I'm going to ask you many questions, but let's go back to the very beginning. You were in bed and you were very sick, and then what?
Good evening, everyone. My name is Naomi Wanjiro. I'm a nurse, a TB champion from Kenya. Sorry, Alan, I want to ask you to repeat that question again. Reason being, I took a lot of MDR drugs. So I tend to forget something
Really?
very fast.
Yeah.
So please come again.
Pole sana.
It's okay.
Let me just go back a little bit.
Okay.
Are you saying that taking MDR drugs actually has that impact on someone?
You know, when you take anti-TBs, there is that is common, the numbness that you get on your hands and on your feet. That is why we use a drug called pyridoxine or vitamin 6. That vitamin prevents the numbness of your hands and your legs, the extremities. Unfortunately, I did not become numb in my legs or my hands, but it affected my nerves in the head. So at times I tend to forget a little bit. Now I remember what you've asked me. Okay.
That's another opportunity to learn something about tuberculosis.
Okay,
Thank
I
you for
got
sharing that.
it is called peripheral neuritis. Those
Right.
doctors in the house will help me understand that. So I got TB of the spine. Unfortunately, it took so long for it to be diagnosed. So it made the bacteria eat my bones, my backbones, L1, L2, L3, and L4. So I became completely bedridden for a whole year. A whole year I could not take myself to the toilet. I could not take myself to take a shower. Everything was being done on me. To a point I was put on a catheter.
And before that, though, you didn't know what you're suffering from for 6 months.
No, I keep going to the doctor. And they did not screen me for TB, sorry to say. And I was working in a TB clinic. So I also blame myself because if I was wise enough, I would have thought this could be TB. But, as they say, TB is for others. I don't want to be screened, the stigma that comes with it. So I tried so much to hide myself. Even the moment that I was told I have TB, okay, I said it's okay, I will take medicine. But when I went to the house, I cried myself out and asked myself, now what will people say? Because having worked in a TB clinic, I saw people being stigmatized because of TB. So I was wondering, now it is me. I have worn that shoe. In fact, for like 3 or 4 months, I did not tell anybody I was having TB. I just told them I hurt myself because I did not want anybody to think about TB.
You speak very powerfully about stigma, and the one thing that I remember the most was you said the stigma start with you stigmatizing yourself.
Now look, I got TB, but I did not want anybody to tell me I have TB. And I did not want to talk to people to tell them that I have TB. Is it not stigmatizing myself? Secondly, my healthcare workers, my colleagues, when I completed my first initial treatment, the 4 oral treatment, I was put on injectables. Nobody wanted to come and inject me. By then, I was living in a single room, a small room. I could not afford a big room by then. Nobody wanted to come. Reason? You will infect us.
Was
My
it because
son.
of lack of education by the health workers?
Yes, stigma. In
But
fact,
do they know? Do they actually know? Or
Yes.
do you find that health workers are also a bit ignorant?
up to date. I can attest now that currently I'm giving treatment to two clients, healthcare workers, but they don't want to come near the clinic. We communicate through the phone. Today is my day to pick treatment. Come with them. And they tell me, do not write my name on that treatment book, TB4. Write someone else's name. Even guess any other name, but don't write to my name. Reason? healthcare worker having TB is not for us, as they say.
And then you talk about you being bedridden, and then apart from just being bedridden, having to treat yourself because nobody else will treat you. So there is an element of dignity in all this, your personal dignity.
The good thing is, I felt a lot of pain in me. And I was happy. Imagine the healthcare worker who was supposed to inject me. The first day I called her. She told me I'm coming. She came the first day and injected me. And you see, this treatment you are supposed to take according to the hours. Don't take today 1 a.m., tomorrow 12 p.m. You have to maintain the hours. So today she injects me. Tomorrow she tells me I will come until 4 hours late. Why? They don't want to come, and I felt like I don't belong to this world. If a health worker like me can stigmatize me to refuse to come, what about a client that is in the community? We are the worst people.
How long did it take you to finally begin to feel better?
At first, I took the 6 months treatment. Let me say, I started by going to the clinic. For 6 months, they did not diagnose TB. And then I was put on treatment. Instead of improving, I became worse. The other signs, the night sweats, the fevers, them went down. But since the bacteria had spoilt my back, it became worse. In fact, there was a time I used a wheelchair. I used clutches to walk because now it became so bad on me. But after taking the 6 months, nothing improving. So I went back and I was put on streptomycin and the 4 orals. After the 4th month, a visiting doctor came to Kenya. And I went to see him. He told me, even if you take treatment, the anti-TBs, you will not improve because the bacteria have already spoiled your back. So I went to India for surgery and came back. When I've already been done surgery, the doctor had taken a biopsy on me. Biopsy is that small meat that is taken for culture. He came back and told me that you have resistant TB. That was the worst news.
How are you coping all this time mentally? How is your mental health at that point? Because it just seems like it's coming from bad to worse. Now, the idea that the TB is resistant to medicine.
The thing that kept me going is to see my son going. Because I was telling myself, if I happen to die now, and already the children playing with my kids are telling him, don't come near us, your mother has TB. What if I die? He would be chased. So I was like, let me be strong enough for my kids. For my kid. That time I had 1 kid. And
You've since had another child?
Yes.
Congratulations. That's worth celebrating.
After the surgery, after I completed the treatment, I went ahead and got 1 more child. And now I'm a mother of 2.
And for me, Naomi, the thing that you talk about ever so powerfully that I like to concentrate on is stigma. But also you're a health worker at the moment. How has your experience as a champion, as someone who's overcome TB, affected your work as a health worker?
First, I identify myself with TB clients. They are very positive about it. In TB clinic, there is that small card that you give a client to go home with. So after we go through the adherence counseling, we've talked, we've agreed, I give them my number. I tell them, in case of anything, call me on this number. So at times they'll call me and tell me my mom does not want to come near me because I have TB. I tell them, I will come to your place. Immediately I'll go visit the family and talk to them about TB. So they will now embrace the client. But the worst part is I cannot do alone. I'm very grateful for our government to bring in the CHPs. They are really passionate about TB and they are working with me through that journey.
What is that? The CH who?
The community health promoters. They are the first line health promoters. So when I have a client, I will definitely call one of them that is nearer that area to go and health educate them about TB.
And the community role is very important in the fight against TB.
Very important. Remember this TB is in the community. So we should fight TB from the community. We get treatment from above, but it is the community that takes the treatment. So it is the community that should be given the treatment.
Right. And you told me something, and I really want people like Naomi to be promoted as much as possible because I think you're doing really important work. You told me something about getting together with other community people. Tell me a little bit about the work you're doing with that.
For me, every day I go to the facility in a TB clinic. This is my 14th year working in a TB clinic. And for those that have gone through the TB disease, we've formed a network of group champion. We call ourselves network of TB champions. That is when we get a client that has TB, the TB champion will also walk the journey with the client, so that the client does not stop taking the treatment to the last drop. Again, the best thing that you can do is send a thief to catch a thief.
Send a thief to catch a thief.
I am the thief here. So if you want to get a client, send me.
Because you know the mannerisms.
Exactly.
You know where they're hiding.
Exactly.
You know how
and
they
let
hide.
me tell you, I cannot stand here in the room here. I cannot look at you and tell you have TB. You have to go to be screened. And you can also screen yourself. Every 6 months, try to screen yourself. Ask yourself those questions. Am I coughing? Not a cough of 2 or 3 weeks. Just a mere cough. Have I lost my weight? Am I having fevers? Am I sweating at night? Some of us women, we don't differentiate when it comes to sweating. You know, you should, when you have TB disease, at night you sweat until those sheets become wet. Some of us, they come and tell me, I think I've started menopause. No. Let's go through the signs and symptoms.
And that's really important. What you're saying is really important because I'm not sure what menopause is and how it feels, but if whatever the case might be, keep TB on the table, right?
Exactly.
It might be sweat, it might be a cough. Keep TB
Think
on the
about
table.
it. Think about it. We are told TB is a very infectious disease, and maybe I have TB now. This is my contact. She is at risk of getting TB. So let me screen myself, be put on treatment to protect my contact.
And you know, can I just say this, Sultani? You are an important guy in the Ministry of Health in Kenya. A very important man. And I think you have a really important person in the spread of the message around tuberculosis. How do you work with people like her to make sure that this message gets further out? This is me handing you over to, so that, because I think there's something to be said about that collaborative effort to push back against tuberculosis.
Yeah, so the place for champions, you know, to be able to advance advocacy at all levels is something that we cannot really overemphasize. And one of the things that we have done at the Ministry of Health is to establish a directorate that just deals with the issues around health promotion and education.
Now that you've listened to Naomi talk,
yes,
I really want you to, yeah?
Yes, and one of the things that I'm thinking about is how we can be able to probably work together with Naomi, find out about the group of champions, and see how we can be able to, you know, inject the work that they are doing into our bigger strategy around health promotion and education.
And build them into your budgets and support them.
Absolutely. And remember, she spoke about the community health strategy that we have actually now put at the forefront. It would really benefit from having that level of champions working together within the community, because the community listens to the community health promoters. They are part of them. They are not detached the way we health workers are detached from the community members. They speak the language of the community members. So it becomes very easy for us to be able to now connect the champions with the community health promoters, what they're already trying to do,
Right.
so that we can be more effective.
Thank you very much. And Madam Minister, Madam Minister, I was just going to say, the role of people like her in making sure that the message gets across. Because the one thing we're learning from all this is that TB is actually a community problem. It is one that cuts across everything. It's not just, it cuts across families, breaks families, people lose jobs, people lose family links and societal links. What role do you see for champions like her?
Champions like Naomi, they play a very important role. You know, the success we have had in terms of HIV and AIDS management as we are now, that we are maybe 95, 98% people. Now nobody's scared about HIV. They can test themselves. Everybody knows there is hope. When you are positive, you go and get help, you'll be okay. But that has been achieved because of some people who really were brave enough that time in the 80s, in the 90s. There were some people who were brave enough to come out and say, no, I'm positive, but now I'm on treatment. And people, they saw with the naked eyes that indeed something is happening, people are getting well. So I'm so proud of my sister here. This is what we need. This is what we need, and especially being a woman, because let me say this, whether it's TB, whether it's HIV, any disease, the most affected is the woman. Whether the woman is sick or it's the man who is sick or the child who is sick. But the woman, one way or another, you are, also, affected or involved. So to come from her and being a health care worker, it's very unfortunate that us in the health ministry, I'm a pharmacist by profession, we're supposed to be champions in the eyes of the people. We are not supposed to be scared. But now you see from the testimony that you are the first ones to be scared. How do we even give hope to a patient from a rural area who really they have no information at all? They're so scared. So if it starts with us. So I want to really to congratulate my sister.
And to invite her to Malawi. She can help.
Exactly.
Yes. She can help with that. She can help with that.
Yes.
And I'm really serious about inviting her to Malawi because, as you're saying, Chua, there's an opportunity. And this approach, this education, this approach, cross-border approach is important. The Kenyan experience could influence the Malawian experience. Isn't that true?
Yeah, exactly. And I think, yes, thank you. No, exactly. And you're right. And I think that's where we have an advantage of a regional approach. Because the regional approach, yes, the cross-border issues that we talked about in terms of referral and all that treatment, but also knowledge sharing, lessons learned, countries being able to know what has worked elsewhere and that could benefit the other country. And we saw that a lot in the occupation. Actually, I was very keen on listening to her. When we were starting the World Bank funded, I think Malawi was also part of it, Southern Africa Tuberculosis and Health System Support Project. One of the components was TB in healthcare workers. And yes, there was infection prevention and control that was promoted already by the government. But honestly speaking, it's not having that much of an impact. And we started introducing slowly that can we also look at occupational health for healthcare workers so that it is beyond just infection prevention and control. Because their workplace is one of the workplaces where they need protection as workers. So they also need to start looking at themselves as workers who need occupational health and safety beyond the infection prevention and control.
Do you want to add to that at all, Sheila?
Yeah, no, I think it's quite clear. I think I'll add from the point of education, because when we're talking about prevention, it means the community should be educated on how to prevent the disease. And through prevention, when we start educating them about prevention, we start educating them about how you get the disease. You start educating them about you should not be afraid when you have TB. I think that goes a long way. And so, even in terms of cost effectiveness. So I think we need to promote prevention. We need to promote behavioral change activities. We need to engage our communities and ensure that they are aware of these diseases, how you can contract them, and how they get treated.
Ladies and gentlemen, let's give everybody a round of applause. Who wants to say what? Any questions from the audience? Any questions from the audience? I've sort of run out. Any questions? Any thoughts? Yes, or thoughts, absolutely. Do you have some thoughts at all, having listened very patiently?
I will just say a couple of things. One is you are building the movement, and that is so fundamental. This does require people like Naomi. In every community, you will find TB, and the voices of the local community are most powerful. And Stop TB and the TB Alliance and the whole effort to build a whole, as you called it, the directorate of testimonials is so important. But second, it's also being able to. We have learned this again and again. We have had to show people that it's okay to talk about you have a cancer. We've had to show people that it's okay to talk about you have HIV. Today we're talking about how it is okay to acknowledge that people have mental health illness. And TB is still in that place where that has not been able to happen. And so that is a fundamentally important part of the story. So is the innovation, so is the political commitment, so is the funding. And all of these, Luchika, I just have to say, your sponsorship, your commitment to rallying the world to know that in every part of the world, there are these communities coming together to fight, that keeps the rest of us going as well.
Right, thank you very much. Thank you, Tool. And this is a unique opportunity where you have Kenya represented here at a senior level, and also the Honorable Minister of Health from Malawi is here. And I'm really curious to hear from the Minister and from Sultani from Kenya. What do you want to tell the partners? What do you want to tell USAID in terms of the relationship and how that relationship can be more effective? What are your thoughts, briefly, if you can, on what ought to happen? What is happening now? How can that relationship be better?
We are making steady progress, even the TB fight. So for us as Malawi, and I know that some African countries are also adopting the same. Well, now we have started what we call the one plan, one budget, one M&E strategy approach to the health sector.
M&E being monitoring and evaluation.
Exactly. Basically, what it's saying in simplest terms is that previously you would have a partner, Stop TB, just focusing on TB. Then I would have another partner just focusing on malaria. Then another one focusing on some other things. So we have so many implementing partners. You have so many strategies. It's very difficult, to manage that kind of scenario. So now with the new plan, one plan, as government, we come up with a plan. This is how we want the health sector to run in Malawi. And then we invite all our partners on the table. Then we work together. We put our resources together. Then we start addressing the issues. It's at least going to improve on service delivery. It also reduce wastages and duplications as well. But it also, address some areas which really you find very little support, like issues of mental health. How many partners have you had who are supporting mental health? None, just a few, So, but as a government, I'm concerned about mental health issues as well. So we are saying, no, this woman already achieved so much in terms of she might be HIV positive, but she's doing very well. But it is the same woman who is also going to have some other issues to do with the mental health. So we are looking at a whole person, not at programs or diseases, but a whole person approach. So
That's
yes.
very interesting, Madam Minister. And I want to bring in Chimwemwe because you talked to me about that, about the fact that different partners participating can cause a little bit of that there's need for synchronization.
Yes, thank you. And thank you, Madam Minister, for bringing that up, because it's quite a big challenge. Even when you come to scale it up to the regional level, it is the same problems. There's a lot of fragmentation. Every partner has their own priority that they want to support. But I think if it comes from us, the ownership is what brings in sustainability. And as the government of Malawi is saying, we have one plan, and we would like the partners to contribute to that plan. That's what brings in ownership and sustainability. And I think we're calling upon all partners. And I think the other issue that I also talked about in our previous conversation is that, yes, supporting the country level efforts. I know there's now lowering of support to this coordinated, collaborative approach at the regional level. And if partners could also ensure that that is focused on in an aligned and harmonized way, it helps us quite a lot because there's ownership and sustainability of that.
Right. And what's the Kenyan experience and what are you saying to your partners about the fact that, how can you improve that relationship in order to make sure that it's more effective?
Okay, so for me, it is three things. Number one, we really value the partnerships that we've had because a lot of the advances we've made, a lot of the results that we've been able to experience are generally because of the partnerships, the robust partnerships that we've been able to have and the support that we have received from our partners. Number two, as I had stated a bit earlier, we are now undergoing a paradigm shift where we are trying to now use evidence because we have been made aware that for every shilling we invest in health promotion and disease prevention, we save a whooping 9 shillings that would have gone into treatment, rehabilitation, and palliation. So we want to walk the talk and try to see if we can be able to save as much as possible towards the 9 shillings. So we are telling our partners, let's walk this exciting journey together. Let's see what we can be able to achieve. So we are currently establishing primary care networks where we are reorganizing our system so that it can be much more receptive to health promotion and disease prevention. And we are really requesting that we work together and establish and achieve this goal. Then number three, we also are we have become more and more aware of the need for what my colleague just talked about, sustainability. We cannot really depend on external support for the rest of our lives. So even as we continue partnering and benefiting from this support, let's also look at how we can strengthen our systems. How we can be supported to strengthen our systems, to ramp up domestic financing so that even as we move forward into the future, we can be able to continue providing these services without the kind of support that we are getting today, or maybe that support can come in as supplementary to our own domestic effort.
You make an interesting point, and it reminds me of the private sector, of employers, all participating in trying to make sure that people stay out of hospital.
Yeah, and that needs to be supported. Because sometimes we think that the transition from external support to domestic support is something that just needs to be dropped. No, it has to be supported so that we can bring in all these players effectively to be able to fill in the gap.
Okay, ladies and gentlemen, thank you very much. And before he even sits down, Dr. Nyaike is sitting next to her too. He's going to make a brief remark to conclude this session that he didn't attend. He is the Director General of Public Health in Nigeria for the federal government. And we want to first of all hear from you about the implementation of policy from the African Union. We've been discussing issues around that. We've been discussing the issues around a regional approach to fighting important situations like tuberculosis, but also importantly, how do you work better with partners? I know it's taken you a lot to get here, so I'll give you this opportunity to close this interaction and to just share your thoughts briefly of what you think ought to happen. Next to you there is, Atul. He's the biggest funder of the fight against tuberculosis. He's the assistant administrator from USAID. We've had the Kenyan experience. We've had from the Malawian Minister of Health, from the First Lady of Malawi, from Chimwemwe, who is from Nepal, and also from Sheila, who is from the African Union. I don't know what you want to say, just say it.
I must apologize. Good evening, everyone. Good evening, everyone. I'm sorry for coming late. I'm struggling to find this place. And so the boss took us to one other place. We had to start negotiating back. I'm sure one of us must have fallen victim of this. You asked a very important question. And you remember I said something yesterday that SDG goal 17 that has to do with strong partnership is very important if we must achieve the remaining 16 to 1. So as a program manager, I had to work with every stakeholder, every partner. So that you will be able to get the best from them. It shouldn't be a master-servant relationship. Even if you are at the driving seat as the government, you must agree. That's the only way you'll be able to also hear from them, and then they will hear from you. You work together because you will have one goal. For instance, the goal is to end TB. So every person on the table should be able to work in alignment with that. I must give them that. You must build that trust, because trust is very important.
And we've also had from people saying that it must be led by the government, and partners need to listen more to what the prioritization looks like from the government side of it.
Whenever I'm reading a text, I feel very uncomfortable when I see must. Must. I feel very uncomfortable with it. It should be led by the government. By the way, what do you mean by government? If I'm in Nigeria, I'm a civil servant, public servant, and I have a Nigerian who is representing USAID. What's the difference between me and him? Because government is also part of him, he's part of the government. So whenever I see must, I feel very uncomfortable. But I prefer to replace it with should be led by the government. Because we must be on the same page.
And that comes from discussion.
Putting the patients at the center.
Yeah. And what about collaboration, regional approach to these problems? What is the experience of Nigeria in relation to the West African region? How are you approaching it? How are you making sure that you're collaborating with other countries?
You said West Africa. It's now a global village. I said yesterday, one TB case somewhere is a TB case everywhere. You could enter a flight from Nigeria in the morning. In the next hours, you're in UK. Then for West Africa, I could even go by road. Couldn't go by flight. So you must work together. In fact, you should have even your transborder collaboration to an extent that, I don't know if someone is from Ghana here. Ghana, when we finished our compendium of best practices, I've had people from Liberia. They came to Nigeria to look at our best practices. I also have a colleague from Ghana. He came to Nigeria to look at our best practices and ask some questions. So we should work together.
And finally, the role of community workers. And also, I think before we get to that, the role of technocrats, the role of politicians, the collaborative effort of politicians and technocrats to make sure that good policy is implemented.
Those are the stakeholders. If you're talking of ownership and sustainability, if you have the proper definition of primary health care, ownership, sustainability comes up. There must be proper community entry, community engagement, and community participation. If you miss it, you won't be able to get to the root of any infectious disease or non-infectious disease, because they are part and parcel. And if you must fight stigma and discrimination, you must give the community the power. So every person is very important. We are even speaking with the parliamentarians, speaking with the policymakers. Of course, the person that has the fund, the Minister of Finance, must know what you're talking about, especially when they do not understand that health is wealth. In some countries, they will ask you, how much are you bringing to the table? But you need to tell them that health is also wealth. You can't quantify it.
Right. Let's give Dr. Nyeka a round of applause, ladies and gentlemen. You are worth waiting for. Thank you very much, sir.
Thank you.
Thank you. Ladies and gentlemen, thank you very much for being so patient and for listening. I'd like to recognize again the presence of Her Excellency, the First Lady of Malawi, who has been patiently paying attention to the proceedings and actively participating, the Minister from Malawi, and everybody else, the Ambassador. Thank you very much for being a part of this. And I know you have no questions. I think everything has been answered. Can I just say thank you very much? My podcast is called Africa Daily. We are the most influential podcast on the continent, if I may say so myself. And if you have a story that you are working on, anything that you're doing in your community that you think needs to be talked about, please let me know. Okay? Thank you very much. And I will now hand over to Liz. Liz has been working hard behind the scenes. Come here, Liz. Let's give her a round of applause. Liz is part of of Luchika's team, and Liz has worked exceptionally hard to make sure that today and all these other events happen. So she deserves all the applause as well. What are we doing next, Liz?
I was just about to request that you give me a few minutes so that I share a goodie bag with the guests that have spoken and honored our invite.
Do you have one for me?
No, unfortunately not. But maybe after the event, I could get you something.
Thank you very much. So, absolutely. So, do you want to take over now?
Thank you very much. As we wait for Dr. Dr. Luchika is here. Thank you very much. It's been a great honor to have all of you, to have this discussion that we were actually really anticipating for a while, and the engagement and the commitment that we have seen. The conversation does not stop here. We are hoping to have follow-ups. We've had statements made. We've had what is happening on the continent. We've had the challenges we are facing and the innovations that we are thinking through and the different approaches. And most importantly for me is that we are able to speak to each other about what is happening in the different countries at a different level, whether it's country-specific or regional. And I'm also hoping that we are able to network, have contact, have these conversations continue. As I said, we'll follow up. I know something big is coming up in Malawi, but also we have something big coming up in Nigeria in December. So we are hoping that we'll have more of you, and this conversation does not end here, that we'll have interactions. And the next time we are meeting, we have updates. I was very excited to hear from the First Lady when she said, we will meet to take stock of what has happened since we spoke. That's a big challenge for us. That means next time we are meeting, we're not having the same stories. we have to take stock. And one thing I know about our dear First Lady is that she's very keen on numbers. So we'll not just tell stories, we'll come up with numbers. Technocrats have been challenged. Dr. Matendechero, technocrats. Dr. Anyaike, technocrats. Our dear minister, besides the political will, we will also want to hear the numbers. Yeah? And then as well, NEPAD, Madam Chimemwe, Sheila, we have been challenged. So next time we are coming up with numbers. We heard that some countries have overshot their targets, but then we know we still have a challenge to end TB by 2030. We've heard from Naomi what that means and what that actually looks like at that level whereby it matters the most. And I liked what Madam Minister said. We put the human being at the center of it all. How do we look at the whole human being? It's not about a programmatic approach. It's about the human being. So it's a big challenge. Most countries are trying to integrate different programs to have universal health coverage. We are thinking of having it in different places, primary healthcare and all that. But then, what's our story next time? Is there a change? And what kind of change are we looking at? How much change shall we have made in our next conversation? That means the conversation continues bilaterally, but then when we gather, there's a story to tell, a story of positive change. Thank you very much for this lovely evening, and I look forward to seeing you one more time in the next event. Thank you very much.
There is food in this direction. Just very, very good dinner that's been served. So if you smell your way to, that will be grand. Thank you very much again.